Assalamu alaikum everyone. I'm Dr. Farhana Kayani. I'm consultant gastroenterologist at Sheikh Khalifa bin Zayed Hospital, Quetta. So moving on to our state of art lecture. So before going on to the session, I would like to invite the chairs for this session. Dr. Shay Rahman, he is a competent and experienced gastroenterologist working at Hayatabad Medical Complex, Peshawar, Assistant Professor Dr. Shay Rahman. Our next chair for the session is Dr. Aftab Haider Alvi. He is Associate Professor of Gastroenterology at Fatma Memorial Hospital, College of Medicine and Dentistry, Lahore. Our third chair of this session is Professor Sharbat Khan. He is Professor of Medicine and Head of Department at Bulan Medical College. Professor Sajid Ubaidullah. He is a renowned name in field of gastroenterology, Professor of Medicine at King Edward Medical University. And Professor Dr. Aftab Mohsin, Principal Rashid Latif Medical College. I believe Dr. Aftab and Professor Sajid Ubaidullah are not here. So thank you, chairs, for being here. So moving on to our state of art lecture, it will be given by Professor Maria Buti. Professor Maria Buti is a professor of medicine and chief of internal medicine and hepatology at the Hospital General University, Barcelona. She has worked in viral hepatitis for more than 30 years, particularly regarding hepatitis B and C. She has many publications regarding that. I believe everybody knows her very well till now. So thank you, Dr. Maria Buti, and she will talk regarding a pertinent issue that is regarding hepatitis B, updates on Delta virus. Thank you.
Thank you very much. It's really difficult to give this presentation here in Pakistan because I am sure that you have more experience than me in hepatitis delta. The prevalence of hepatitis delta is higher in Pakistan than in my country, than in Spain. But I have devoted my life to hepatitis delta, and for this reason, I have been able to see a large number of patients with hepatitis D. In my country, that is not a very frequent disease. Probably I have seen more than 100 patients with hepatitis D. The proportion of people with hepatitis B infected with hepatitis delta, it's unknown. There are estimations, but it's very difficult to know how many people are infected. It has been estimated in recent studies that the overall prevalence, it's around 5%. But there are other studies suggesting that the prevalence could be much higher, 14 or 15%, with a very heterogeneous distribution and with some hot spot areas such as Mongolia and Sub-Saharan Africa. There is a very nice review performed by Mario Risetto, the physician who discovered hepatitis delta at the late 70s, showing that the prevalence of antibodies in the last decade in HBs antigen carriers is particularly higher in eastern parts of Africa and also in some parts of Asia. And it's an important contributor to hepatitis B associated disease in Sub-Saharan Africa. When you look at the prevalence of hepatitis delta, it's completely different if you look at blood donors, that the overall prevalence is very low, or if you look at patients with liver disease. If you look in a hospital, in patients with cirrhosis, or even more in patients with hepatocellular carcinoma, the prevalence of the infection is much higher, around 18–20%. And if you look at people with risk factors, that are people who inject drugs or commercial sex workers, men who have sex with men, hemodialysis recipients, then also the prevalence is higher. So very low in blood donors, high in patients with liver disease, and also intermediate in patients with risk factors. Then, having this map, who should be screened for hepatitis delta? And this is an important question, and guidelines disagree. If you look at these guidelines, the recommendation is systematically we need to exclude co-infections in all HBs antigen positive people. That means exclude hepatitis D, hepatitis C, and HIV. If you look at ASLD guidelines, then it's completely different, only screening for risk factors. Risk factors and also individuals with elevated ALT and AST with low or undetectable HBV DNA. But at the end, it's difficult to get the information of people who are at risk, because the majority of patients don't tell if they have a risk factors, and the majority of us physicians don't ask systematically to our patients if they have a risk factor. So I think it's better the European guidelines that clearly suggest to exclude hepatitis delta in all HBs antigen positive. And these are data from my hospital. In my hospital, usually we screen patients on risk factors, but last year we introduced reflex testing for delta. That means that all HBs antigen people were tested for delta. And we found that reflex testing increased the prevalence, increased the absolute number of patients diagnosed with chronic hepatitis delta, but not only increased the numbers. What is really important of this study is that 60% of the anti-delta positive individuals didn't have any risk factor. So if you screen by risk factors, you are not going to diagnose this 60% of people without any type of risk factor. And our results advocacy for universal screening for patients who are HBs antigen once time. The second thing that is important, that is not all patients with anti-delta antibodies have really chronic delta infection or active delta infection. To diagnose active delta infection, you need to test for viremia, for HDV RNA, and you can see that the prevalence of HDV RNA in anti-delta positive people is between 40 and 73%. And in cases that RNA is positive, this is associated with higher rates of liver disease, complications, and liver cancer. So this is the algorithm for the evaluation of hepatitis delta. HBs antigen positive, test for anti-delta, and if anti-delta is positive, test for HDV RNA. HDV RNA negative, manage as a standard of care for hepatitis B. And if HDV RNA is positive, then we need to look at ALT levels and to assess fibrosis to diagnose chronic hepatitis delta. I mentioned yesterday that patients with chronic hepatitis delta have more severe outcomes than mono-infected patients, a higher risk of developing cirrhosis, higher risk of developing HCC, hepatic decompensation, death, and need for liver transplantation. And this higher risk was also tested in our cohort of patients, and this is a study from my center, looking at the probability of developing clinical events in patients with chronic delta in relation to the presence of detectable HDV RNA. In green, in the green columns, you can see the progression to cirrhosis, liver decompensation, HCC, and liver-related death for those patients with detectable viremia, and this is much higher than the brown columns that show those with undetectable viremia. So these patients with detectable viremia are candidates to treatment, and these are the recommendations. Treat patients with detectable viremia with interferon for 12 months, and this is the same recommendation for EASL and IASLD guidelines. The duration of treatment 12 months, and the indication in those viremic patients with high ALT levels. In addition, the guidelines also recommend to look for hepatitis B viremia, HBV DNA, and those patients with detectable viremia for B are also candidates to treatment with nucleoside analogs. And finally, the recommendation for ASLD is that given the limited efficacy of the current treatment with interferon, it seems reasonable to refer patients to specialized centers that offer access to experimental therapies for hepatitis delta. These are the results using interferon in patients with chronic hepatitis delta, that it's at the end of treatment, a quarter of them achieve undetectable viremia. This undetectable viremia seems that is maintained in a short period of time, but if you follow these patients longer, if you follow more than 5 years, the majority of patients relapse. That means that at the end, a very low proportion of patients, around 12%, maintain a sustained virological response. In addition, interferon has adverse events, and not all patients are candidates to receive this drug due to contraindications. What is good is that those patients, this a small subset of patients that achieve a sustained virological response, have a lower risk of developing clinical events and a lower risk of complications. And you can see in red patients treated with interferon. Even those not achieving a sustained virological response, they only receiving treatment, there is a lower rate of complications in contrast with those without treatment or in those receiving only nucleoside analogs, because nucleoside analogs are not effective. Similar results were observed in the left part of the slide in our cohort, and those patients treated with interferon had a better outcome. Now we have new treatment options for hepatitis delta. Some of them are still under investigation. And here you have listed these different drugs. Bulevirtide, an entry inhibitor that is administered by subcutaneous injection. Lonafernib, a prenylation inhibitor that is a step used for the replication of delta, and oral drug. Nucleic acid polymers that inhibited the release of hepatitis B from the hepatocytes, interferon lambda, and also all of these treatments that Professor Esteban has shown before that could be useful. If they are useful for hepatitis B, also can be useful for hepatitis delta. So let's start with bulevirtide, that is the only drug approved now in European Union by the European Medicine Agencies. As you know, hepatitis B and hepatitis delta needs a receptor to enter to the cells and to infect the hepatocytes. And bulevirtide, it's an entry inhibitor. It acts as a cellular target and blocks the entry of hepatitis B and hepatitis delta inside the hepatocytes. It's administered subcutaneous, and the indication in Europe that has a conditional approval is for patients with chronic hepatitis delta, compensated liver disease, HDV RNA positive, should be administered subcutaneous as a monotherapy or co-administered with nucleoside analogs. This indication, it's a very unusual indication because it was based on the results of phase 2 studies, and this is the phase 2 study that allows this conditional approval. It's a study performed in 120 patients. These patients were randomized in 4 different arms to receive mircludex, bulevirtide, plus TDF, 3 different doses, 2, 5, and 10 milligrams. And there is a control arm with TDF for 48 weeks, and then patients were followed until 1 year. The study shows that there is a reduction in HDV RNA levels, that it seems dose dependent, but at the end, the primary endpoint of the study, that it's a weak endpoint to log declines in the level of viremia, was similarly reached with 2 milligrams and 5 milligrams. And what is more important, if you look at the graph, that after 24 weeks of treatment, during treatment, patients achieved these 2 log declines, but when we stop treatment at week 24, the majority of patients relapse. So it has a transient effect and suggests that we need longer treatment. For this reason, another study was designed with longer treatment, now 48 weeks, and it evaluates 2 different doses, 2 and 5 milligrams, but now in monotherapy or combined with PEG interferon. And there is a 4th arm with PEG interferon monotherapy. It's a randomized study, and now the endpoint is stronger. It's HDV RNA undetectable. And you can see that patients, particularly those treated with 2 milligrams of mircludex plus PEG interferon, achieve at the end of treatment, 50% of them achieve undetectable viremia, and a proportion of these patients also lost HBs antigen. And these 2 studies were very useful to get the approval by the EMEA. Now there is an ongoing study that probably will answer a lot of questions that we have regarding treatment of hepatitis delta. And this study, it's a phase 3 study. It's compulsory by EMA to do this study. And in this study, patients with chronic hepatitis delta compensated liver disease were randomized to receive bulevirtide 2 or 10 milligrams for at least 3 years. And there is an observation arm, is delayed treatment, start treatment at week 48. This is the largest randomized study performed ever in hepatitis delta, and the primary endpoint is the combined response. That means HDV RNA undetectable or 2 log decline in the levels of viremia from baseline and ALT normalization. The study is ongoing, but in the last EASL meeting, Heiner Wedemeyer showed the primary endpoint results at week 48. At week 48, patients with normal ALT and decline in the levels of viremia was 48%. So that means half of the patients reach this primary endpoint. And if you like to know how many of them were completely with undetectable viremia, the proportion was lower, was 12-20% for 2 milligrams or 10 milligrams. But there is no statistical difference between 2 and 10 milligrams, supporting that the European indication of the 2 milligrams is the right dose. Very important, patients who achieve decline in the levels of viremia have an improvement in the liver stiffness, so suggesting and showing that this drug was associated with significant reduction in liver stiffness. And regarding safety, that is an important question. Patients treated with both 2 milligrams or 10 milligrams have the same rate of minor adverse events than those without treatment, showing that monotherapy with bulevirtide is safe, very well tolerated, and there is no serious adverse event related with this compound. The only adverse event is an increase in bile acids, and this increase is transient. It's also dose dependent, higher with the higher dose, and it's observed in both groups. I was able to show at EASL meeting that patients treated with bulevirtide reported better quality of life. This is the survey on quality of life, showing that is an improvement in health distress, in positive well-being, and also hepatic health components, showing that there is an improvement versus controls. And as I mentioned yesterday, now in Europe we are treating patients with this drug, with bulevirtide, and the results that we observe in the real life is very similar than those observed in the registration studies. Patients treated with 2 or 10 milligrams achieve a positive response in a lower proportion than in those patients treated with PEG interferon plus bulevirtide, but we cannot strictly compare these results because there are real-world results. There are not head-to-head studies. We also have data extending the treatment duration for more than 48 weeks. These are 3 cases treated with this drug, 2 cases treated for more than 3 years, and showing maintained virological response on treatment, normalization of ALT levels, and improvement in portal hypertension, while when you stop this drug early after 1 year, patients relapse, and suggesting that this drug has to be given in monotherapy, in long-term treatment. And also I mentioned these results showing that this drug can improve portal hypertension in those patients with advanced liver disease and with portal hypertension. The second drug that is available and phase 3 studies will finish at the end of this year is lonafernib. Lonafernib, it's an oral drug, it's a prenylation inhibitor that it is now tested in a phase 3 study with or without interferon. We have very few results from the phase 2 dose-finding study on lonafernib and ritonavir. This study was performed in Turkey by Yurdaydin. And in this study, complicated study, they used different doses of this drug, lonafernib, 75 milligrams, 25, 50 milligrams, with or without ritonavir. Why ritonavir? Because lonafernib alone is associated with an important side effects, particularly the high dose. And boosting this drug with ritonavir, we can decrease the dose of lonafernib. And for this reason, this drug now is developed in combination with ritonavir. These are the results, the phase 2 study design, showing decline in the level of viremia, particularly in those that are taking the dose of 25 milligrams of lonafernib plus ritonavir with PEG interferon. This is the ongoing study, also a large study, including more than 400 patients with hepatitis delta, a global study. Patients will receive this drug in monotherapy, lonafernib 1 arm with ritonavir, and another in combination with PEG interferon, and there is a control arm with placebo. The study has enrolled all patients, and we expected final results at the end of this year, and probably this drug will also get the approval from FDA and the European Agency. And finally, I would like to finish with just mention the nucleic acid polymers, the interferon lambda, and all drugs in development for hepatitis B that can be useful also for hepatitis delta. There is no vaccination for hepatitis delta, and my take-home points are that hepatitis D is often undiagnosed. Chronic hepatitis delta patients have a higher risk of disease progression, decompensation, and hepatocellular carcinoma than those with chronic hepatitis B. Factors associated with disease progression are cirrhosis and persistent delta viremia. PEG interferon is the recommended treatment for chronic hepatitis delta. Nucleoside analogs are not active against hepatitis delta. Bulevirtide is approved and used in Europe, and now we have different drugs against different targets in development for this disease. Thank you very much for your attention.
Thank you, Professor Maria Buti, for such an informative and pertinent talk. So I would like our respectable chairs for their commendable and precious comments regarding the talk.
Thank you, Professor Maria. I have a few areas where I would like to seek your opinion. One is about the universal screening of HBs antigen positive for HDV, and the EASL has recommended universal screening. Here in Pakistan, and particularly the northern Pakistan, to where I belong, we probably follow the American practice that we usually only screen HBs antigen positive in high risk or where the clinical situation warrants. So my question is, what is the practice in your area? Whether you people adhere to the EASL guidelines? And I have two more questions.
You are using the EASL guidelines clearly in my country, and now our Association of Study of Liver Disease, the Spanish Association of Liver Diseases, are now also recommending reflex testing. I think here in Pakistan, having the prevalence that you have on hepatitis delta, I think it will be very useful to apply the European guidelines, because you are going to diagnose more patients. I mentioned that in my country, 60% of patients didn't have any risk factor for delta. Why not to test everybody now that we are going to have new treatments that can change the outcome of the disease?
I have another question. In your previous talk, you made a case for treating all immunocompetent HBV patients. So if these patients have also HDV as well and the LT is normal, would you go for the treatment of HDV in this population?
Immunotolerant patients with hepatitis delta, this is your question?
Yes, immunocompetent HBV with HDV as well.
Immune tolerant.
Immune tolerant.
Yeah. This is not a very often situation because the majority of patients with hepatitis delta have inhibition of B replication. So I haven't seen immune tolerant patients with delta. But if you have an immune tolerant patient with active delta, my recommendation is to go beyond the guidelines and treat this patient because this patient with active replication of both viruses, I think, have a very high risk of developing complications. But I haven't, to be honest, I haven't never been a patient with this combination, but probably in your country you have these patients.
Professor Sharwat Khan.
Very good presentation by Dr. Maria and latest updates regarding hepatitis D, the new drugs. So, are these two drugs like bulevirtide and lonafarnib are safe in pregnancy?
There is no experience because in the clinical trials, pregnancy is clearly an exclusion criteria. Even people that are planning family, it's an exclusion criteria for entry in clinical trials. I am not aware that there is any case in the register of pregnancy during bulevirtide or lonafarnib treatment. I am sure that this will appear in the future, but up to now, I am not aware.
Thank you.
Thank you very much. Wonderful lecture, very informative. But over here, we have majority of those cases which already developed cirrhosis are the compensated cirrhosis. Are these medication are indicated for that or any response with that?
Is not indicated. If you look at the conditional approval, decompensated cirrhosis are excluded. And I think it will be excluded until the drug has the approval, not this conditional approval, the true approval. I am not aware that patients with ascites or even decompensated patients have been treated with this. And probably, I think these patients will continue to be excluded because, as you know, in drugs that are in development or have the conditional approval, they appear the complications, and particularly if patients die during the trial, this compromises the development of the drug. So by sure, this will be tested in these populations, but when the approval was confirmed.
Thank you, respectable chairs and valuable audience for being here. So with this, we conclude our session. We will take break for lunch and prayer. Sorry. All right. Sorry.
Thank you. Dr. Maria, thank you very much for your excellent talk. I have a question about the post-transplant patient. When you have delta with cirrhosis, they go to liver transplant. And for the post-transplant time, what is the role of bulevirtide and the new medication? Is there any data on it?